The following podcast is part of a certified educational activity titled Taking a New Look at Cancer-Associated Venous Thromboembolism. How is emerging evidence influencing guidelines and practice? Access the entire activity and complete the post-test at peerview.com/TGQ860. Downloadable slides and practice aids are also available.
Hi, my name is Rob McBain. I'm a professor of medicine at the Mayo Clinic in Rochester, Minnesota, and I'm the chair of the Division of Vascular Medicine. Today, I'm delighted to take us through a discussion of cancer-associated venous thromboembolism and how the emerging evidence influences guidelines and clinical practice. Let's just spend a few moments talking about the epidemiology of this problem. Cancer, as you all know, is common. In 2018, there were nearly 2 million new cancer diagnoses in our country. And currently, we have 14 million cancer survivors. 1 in 5 of these individuals will develop a venous thromboembolism, and this accounts for nearly a fifth of the venous thromboembolism burden in our community. We know that cancer increases the risk of venous thromboembolism by more than 6-fold, and not only for the incident venous thrombosis, but the risk of venous thrombosis recurrence is also greatly increased by more than 6-fold. And for those individuals who've had cancer and a venous thrombotic event and are not able to take anticoagulants, we know that the annual risk of recurrence is more than 30%. Further, we know that incident venous thrombosis is cancer site specific. Each of the malignancies carry an increased risk of thrombosis relative to patients without malignancy. However, as you can see, there are several cancers which are particularly prone to develop thrombosis. But in general, brain cancer, pancreatic cancer, cancer involving the upper GI tract, and lymphoma stand at the top of the risk for cancer-associated thrombosis. We know that the risk of venous thromboembolism is cancer stage specific. So as you can see in this very large population of patients from a Danish national registry, those individuals who have stage 3 and 4 cancer have a greatly increased risk of venous thrombosis compared to those with lesser stages. We also know that the risk of venous thromboembolism is cancer duration specific. As you can see from this table, most of the thrombotic events are going to occur within the first 3 months of cancer diagnosis. And then we know that this risk is also directly related to cancer-specific treatment. Those individuals who are actively receiving chemotherapy have a nearly 7-fold increased risk of venous thromboembolism compared to patients with cancer who are not receiving chemotherapy. This table shows a number of the chemotherapeutic agents which are particularly prone to increase the risk of venous thrombosis. And we know that cancer-associated venous thrombosis adversely impacts survival for our patients with malignancy. Those patients who have a cancer and an associated venous thrombosis have a greatly increased risk of mortality compared to patients who have the same malignancy but don't have a venous thrombosis diagnosis. We know that venous thrombosis in cancer is the second most common cause of cancer death, secondary only to cancer progression. And nearly half of these individuals will have a distant metastasis at the time of their death. So in summary, 1/5 of all incident venous thrombosis in our community is attributed to cancer. And 1/5 of all cancer patients will develop a venous thromboembolic event. We know that this risk is cancer site specific, stage specific, duration and treatment specific. We know that the risk of recurrence is high in these patients, and we know that venous thromboembolism adversely impacts overall survival. Next, I would like to talk about venous thromboembolism prevention. And I think the best way to do this is to introduce a case. So this is a patient that I saw about a year ago. And his story was that he had a new diagnosis of localized pancreatic cancer. He had a port placed and was initiated on full FOLFIRINOX therapy. At the time that I saw him, he was actually doing quite well with an ECOG performance score of 0. And as you can see, his laboratory test results were very reasonable. So the first question is, should this patient with localized pancreatic cancer be initiated on primary venous thrombosis prophylaxis with low molecular weight heparin, yes or no? We're going to start our discussion with low molecular weight heparin, and later we're going to talk about the direct oral anticoagulants. In order to address this question, it's important to determine what the guideline statements are with respect to these three important societies. It's also important to note that these guidelines are anticipated to be updated very soon and may change. As we've discussed, we know that cancer-associated venous thrombosis varies with respect to the timing of diagnosis. We know that the risk varies over the course of illness, and that it is highest during the first few months of the cancer diagnosis. We know that those patients who are undergoing cancer-associated surgery have an increased risk, and as we've discussed, following the initiation of chemotherapy, and there are several specific chemotherapies of concern, we know that the risk is greatly increased. And lastly, we know that following the development of metastasis, this risk will increase. This slide highlights that the risk of venous thrombosis is highest during the first few months of the diagnosis. And you can see that the vast majority of the activity for these various tumors is occurring within the first 90 days. So the question is, does primary prophylaxis reduce the risk of cancer-associated venous thrombosis in patients who are otherwise being treated as an outpatient? And for this question, there are two major trials of low molecular weight heparin, which I think we should review. The first trial is the PROTECT trial, and in this trial, more than 1,000 patients were randomized to receive low molecular weight heparin, in this case nadroparin, or placebo. Note that these patients were ambulatory, being treated as an outpatient. They had metastatic or locally advanced solid tumors and were receiving chemotherapy. The primary endpoint of this trial was symptomatic venous or arterial thromboembolism within 4 months. Here are the primary efficacy outcomes, and what you can see is that nadroparin reduced the risk of the primary endpoint by almost 50%. You can see that deep vein thrombosis, pulmonary embolism, visceral deep vein thrombosis, stroke, or thromboembolism were all reduced by more than 50%. And this did not come at the expense of major bleeding. In this study, the rates of major bleeding in the active treatment arm were very low and did not differ from placebo. This second study is the SAVE-ONCO trial, very similar to the PROTECT trial. More than 3,000 patients randomized to low molecular weight heparin, semloperin, or placebo. As in the previous trial, the primary endpoint was symptomatic venous thrombotic events or venous thromboembolism-related death, 3.5 months. You can see that the primary endpoint of this trial was reduced by more than 50%, with a more than 50% reduction in deep vein thrombosis and pulmonary embolism. Note also that venous thromboembolism-associated death, though lower, was not statistically significantly lower in patients who received low molecular weight heparin. This therapy did not come at the expense of major bleeding, which did not differ between low molecular weight heparin arm or the placebo arm. This is an important meta-analysis looking at low molecular weight heparin preparations, and you can see 9 randomized clinical trials, the venous thromboembolism rate reduced by almost 50% with a relative risk ratio of 0.54. Major bleeding not statistically significantly greater in those individuals receiving low molecular weight heparin. The problem with this is that ambulatory patients don't particularly want to be taking an injectable parenteral medication every day. So this is the Phragmatic trial, and one of the issues with the Phragmatic trial, which was a randomized trial of dalteparin versus placebo, was what was the quality of life and compliance to low molecular weight heparin treatment. And you can see that those individuals who were randomized to receiving dalteparin had reduced quality of life, and in fact, complete compliance with drug therapy was less than 20%. Less than 40% of patients had received more than half of the doses. So let's get back to our patient with localized pancreatic cancer. Should he be initiated on primary prophylaxis with low molecular weight heparin? Yes or no? The guidelines would say no. The only exception being those individuals with very high risk tumors and tumor scores, or myeloma receiving thalidomide or thalidomide-like medications for their treatment. It's important to note, however, that these guidelines are anticipated to change with the new direct oral anticoagulant data recently published. What if our patient is hospitalized for a medical complication? Should they receive prophylaxis during that setting? And the guidelines universally would say yes, we should give DVT prophylaxis during hospitalization. What if our patient needs to have major surgery? Should they receive primary prophylaxis during that setting? And all of the guidelines would uniformly say that low molecular weight heparin for DVT prophylaxis under those circumstances is very reasonable. Next, let's address the question of whether risk assessment tools work to identify individuals who are most likely to benefit from primary prophylaxis. The most widely quoted risk assessment tool is the Khorana score, and the Khorana score assesses risk by determining whether or not the patient has a high-risk cancer type, and then several laboratory tests drawn pre-chemotherapy, including the platelet count, the hemoglobin level, and the leukocyte count. And then lastly, a simple assessment of the body mass index. By taking each of these variables and applying them to this risk score, the patient's risk of venous thromboembolism can be assigned to either low, intermediate, or high-risk categories. In this slide, you can see what the expected venous thromboembolism rate at 2.5 months would be depending on this risk. Well, what would happen if we used the Khorana score and went back to the trials that I've already talked about and only gave DVT prophylaxis to those individuals at the highest risk, those with Khorana scores of greater than 3? And you can see that if those individuals were provided with low molecular weight heparin, there would be a substantial, meaningful reduction in the venous thromboembolism rate with a number needed to treat for those high-risk patients of only 15. A very similar analysis was done for the SAVE-ONCO trial, and you can see that if we just gave DVT prophylaxis to the very high-risk patients, the number needed to treat would be only 25. The next question is, are there other risk scoring tools? And the answer, of course, is yes. And the vast majority of these have been based on the Khorana score with slight modifications. So in this slide, you can see 5 different risk scoring tools. Many of these have simply added on variables to the Khorana score. For example, the Vienna score added the D-dimer and the soluble P-selectin measure. The PROTECT score added chemotherapeutic variables. TriOnco added genotyping, and then the CAT score added fibrin D-dimer but removed some of the other variables. And you can see that some of these tools are validated and others are not. Well, now what about trials of the direct oral anticoagulants for venous thromboembolism prophylaxis? Here are the direct oral anticoagulants, and you can see that there are direct factor Xa inhibitors, apixaban, rivaroxaban, and edoxaban, and 1 direct thrombin inhibitor. We now have data for DVT prophylaxis in cancer patients for apixaban and rivaroxaban. The first trial is the AVERT trial. In this trial, ambulatory patients with cancer who had cancer progression or partial remission starting new chemotherapeutic agents, and importantly, having a Khorana score of 2 or greater, were assigned to receive either low-dose apixaban or placebo. The primary endpoint of this trial was the first episode of venous thromboembolism at 180 days. Here are the trial results. You can see that the primary endpoint was substantially lower in those patients who were assigned to the apixaban arm compared to the placebo arm. This comes with a nearly 50% reduction in deep vein thrombosis with a more than 50% reduction in pulmonary embolism. On the right side of the screen, you can see the Kaplan-Meier analysis of these events. This is the safety data for the AVERT trial, and you can see that there was an increased risk of major bleeding for those patients who received apixaban. The mortality rates were similar for both treatment arms. This second trial is called the Cassini trial and had a very similar design compared to the AVERT trial. This trial of more than 1,000 patients randomized to prophylactic dose rivaroxaban or placebo was to evaluate the first episode of venous thromboembolism at 180 days. Now, different from the AVERT trial, for patients getting into the Cassini trial, they had to undergo a baseline ultrasound to exclude pre-existing venous thromboembolic events. These are the efficacy endpoints for this trial, and you can see that the primary endpoint of venous thromboembolism at 180 days was 6% in the rivaroxaban arm compared to 8.8% in the placebo arm. If one limited it to the evaluation to the primary endpoint during the intervention period, you can see that there was a more than 50% reduction of thrombotic events in the rivaroxaban arm. Major bleeding was 1% greater in those patients who received active therapy with rivaroxaban. Clinically relevant non-major bleeding was essentially the same between the two arms. In summary, for primary VTE prophylaxis, the routine use of low molecular weight heparin in unselected or low-risk cancer patients is not currently recommended. For high-risk outpatients, those with Corona scores of greater than 3 or advanced pancreatic cancer, one could consider low molecular weight heparin prophylaxis. For hospitalized and postoperative patients, prophylaxis should be given. And this new direct oral anticoagulant trial data from the AVERT investigators and the Cassini investigators may soon impact guideline recommendations for ambulatory patients with malignancy. Lastly, I would like to discuss cancer venous thromboembolism treatment. Let's go back to our patient. Remember that this was a 65-year-old male with localized pancreatic cancer who was receiving chemotherapy with FOLFIRINOX. Several weeks after starting chemotherapy, the patient developed dyspnea and chest pain. Here is his CT scan, and you can see that there is a large volume of pulmonary embolism in both the right and left lobar and segmental pulmonary arteries. Here is his duplex ultrasound, and you can see that there is an extensive deep vein thrombosis involving the right femoral vein. So let's talk a bit about the cancer-associated venous thromboembolism treatment trials. Here is perhaps the most important trial, now more than 10 years old, called the CLOT trial. To get into the CLOT trial, patients with active cancer had to have experienced an acute symptomatic venous thromboembolism. In this trial, more than 600 patients were randomized to either receive dalteparin or dalteparin bridged to warfarin therapy. The primary endpoint of the trial was symptomatic venous thromboembolism recurrence. As you can see from this outcomes evaluation, low molecular weight heparin with continued use dalteparin significantly reduced the risk of recurrent venous thromboembolism compared to warfarin, with a number needed to treat of only 12. Note also that continuous therapy with dalteparin did not greatly increase the risk of major bleeding. Importantly, there was no difference in survival between these two treatment arms. But as you know, low molecular weight heparin has limitations. The injections can be painful and can cause ecchymosis. Cost for some of our patients can be prohibitive. And many of these patients will develop thrombocytopenia related to their cancer or cancer treatment, and this raises concerns about the risk of heparin-induced thrombocytopenia, which may cause treatment interruptions. We don't have a great antidote for patients who are receiving low molecular weight heparin should they bleed, and for those patients who have renal injury related to their cancer or cancer treatment, these individuals may have a limited ability to use low molecular weight heparin. Well, what about the novel anticoagulants? Can these be used for the acute treatment of venous thromboembolism in our cancer patients? Again, here are the different choices for the novel anticoagulants. We have the direct factor 10 inhibitors and the direct thrombin inhibitor, dabigatran. We now have data for 3 of the direct factor 10 inhibitors, apixaban, edoxaban, rivaroxaban, suggesting that this may be an effective treatment. This is the Hokusai venous thromboembolism cancer trial, which assessed this hypothesis of whether the direct oral anticoagulants could be used for the treatment of patients with an acute venous thrombotic event. In this trial, more than 1,000 patients were randomized to either low molecular weight heparin transition to edoxaban or dalteparin as primary therapy. Therapy was to continue for at least 12 months, and the primary endpoint of the trial was recurrent venous thromboembolism or major bleeding as a combined endpoint. Here you can see that the primary outcome composite of recurrent venous thromboembolism and major bleeding did not differ between these 2 treatment arms. Recurrent venous thromboembolism was 8% in those receiving edoxaban and 11% for those receiving dalteparin, which did not quite meet statistical significance. Major bleeding was higher in the edoxaban arm compared to the dalteparin arm with a hazard ratio of 1.77. This table reviews the specific venous thromboembolism recurrence outcomes and the major bleeding outcomes. What you can see in this trial result is that there were no confirmed fatal thrombotic events occurring in either arm. Deep vein thrombosis was reduced in the edoxaban arm, as was symptomatic venous thrombosis. From a major bleeding perspective, there were no fatal bleeds in the edoxaban arm and 2 in the dalteparin arm. The vast majority of the bleeding events occurred from an upper GI source. This trial is the SELECT-D trial, which compared rivaroxaban to dalteparin in more than 400 patients with cancer-associated acute symptomatic venous thromboembolism. What you can see is the recurrent venous thromboembolism rate was lower in those individuals who were assigned to the rivaroxaban arm. Major bleeding did not differ between these 2 treatment arms. This table highlights the outcomes for the SELECT-D trial. And what you can see is that there was a significant reduction in venous thrombotic events for patients assigned to rivaroxaban, 4% compared to 11% in those receiving dalteparin. Major bleeding, slightly higher in the rivaroxaban arm, though it did not reach statistically significant difference. Clinically relevant non-major bleeding, however, was significantly higher in those patients assigned to the rivaroxaban arm. There was no difference in overall survival at 6 months. Like the Hokusai VTE cancer trial, a major concern for the direct oral anticoagulants have been those individuals with GI malignancy and concerns regarding GI bleeding. In this slide, you can see the rates of GI bleeding from upper intestinal tract and lower intestinal tract sources. Note also that the overall mortality was very similar between the rivaroxaban and dalteparin arms. Lastly, this is the ATOM VTE trial, which compared apixaban to dalteparin for patients with cancer-associated venous thromboembolism. In this trial, 300 patients were randomized to receive apixaban or dalteparin for 6 months. The primary endpoint of this trial was major bleeding. This table shows a difference between the ATOM trial and the other 2 trials that I talked about with regards to enrollment. In the ATOM trial, patients with upper extremity deep vein thrombosis Splanchnic vein thrombosis, cerebral vein thrombosis were all qualifying thrombotic events for trial enrollment. In the ATOM trial, there were no major bleeding events in those individuals assigned to apixaban and very few major bleeds in those assigned to dalteparin. When the secondary composite endpoint of major bleeding plus clinically relevant non-major bleeding was compared between the two arms, you can see that there is no difference. There were significantly fewer venous thrombotic events, recurrences in those patients assigned to apixaban relative to dalteparin, and here you can see the outcome for the secondary endpoint of venous thromboembolism recurrence. Arterial thrombosis occurred in one patient for both arms. The ATOM investigators sought to determine the satisfaction of anticoagulation delivery for those patients assigned to either receive apixaban or dalteparin. To do this, each month, patients filled out a modification of the Duke Anticoagulation Satisfaction Survey. This slide shows the questions across the top, and along the side, the results for each of the months or cycles with which the patient filled out these surveys. I've color-coded the results, and for those boxes with a lighter color, the satisfaction survey favored apixaban significantly. For the darker colored boxes, the results favored dalteparin. And as you can see in this slide, the vast majority of patients preferred oral apixaban over parenteral dalteparin. Premature discontinuation rates were substantially lower in those individuals assigned to apixaban versus those assigned to the dalteparin arm. And you can see that there are a lot of trial investigations ongoing. This table summarizes the current activity with respects to treatment trials in this space. Well, what do the guidelines say about the use of direct oral anticoagulants for the acute treatment of venous thromboembolism? It's important to note that each of these guidelines are somewhat dated. The ASCO guidelines would say that DOACs are not currently recommended. The updated NCCN guideline, following the publication of Hokusai VTE and SELECT-D, have both said that yes, these medications can be used for our patient with cancer-associated venous thrombosis. Again, the European guidelines are somewhat dated and had no comment regarding this question. If we get back to our patient with pancreatic cancer and acute venous thromboembolism, the question is, would we use a direct oral anticoagulant for that individual? And I think the answer is, based on the data that we've just seen, that a direct oral anticoagulant would be very reasonable. The direct oral anticoagulants would reduce the need for parenteral injections, may increase the patient's compliance and adherence to medications, and will certainly reduce the burden of management of the associated venous thrombosis along with the other variables related to cancer treatment. It's important to note that these guidelines are anticipated to be updated to include comments on the direct oral anticoagulants in the very near future. Based on the data that we've just reviewed, the new updated guidelines would support the use of a direct oral anticoagulant for the acute treatment of venous thromboembolism in patients with cancer. Here are the new guidelines. In summary, the Hokusai Cancer VTE trial data, SELECT-D trial data, and ATOM VTE trial data all suggest that direct oral anticoagulants are as effective as dalteparin in the treatment of cancer-associated venous thromboembolism. Bleeding complications remain a concern, particularly for those individuals with upper GI malignancies and the risk of GI bleeding. I want to thank you for your attention today. I hope that you found this information useful in the management of cancer patients.
This activity has been jointly provided by Medical Learning Institute Incorporated and PVI. Peerview Institute for Medical Education. Thank you for listening. Download materials and complete the post-test for instant credit at peerview.com/TGQ860. Supported by an educational grant from the Bristol-Myers Squibb and Pfizer Alliance.